56-year-old patient with diabetes is admitted for a foot wound and is diagnosed with osteomyelitis. The treatment plan includes 6 weeks of IV antibiotics after discharge. What is the most appropriate way to provide long-term IV access for this patient? Give you 3 seconds to pause. Once you're ready, press play to go on. Alright, the correct answer is D, place a PICC line. The PICC line is a peripheral inserted central catheter, and it can be used to provide long-term IV antibiotics. 56-year-old patient is diagnosed with osteomyelitis and will need 6 weeks of IV antibiotics after discharge. A PICC line is ordered. Who is qualified to place the PICC line in the hospital settings? Give you 3 seconds to pause. So the answer here, it could be the PICC line nurse. So there are phlebotomists who is drawing the blood, but there's also a nurse who is really good at putting PICC line. So PICC line nurse, and they use an ultrasound and such, or an IR, Interventional Radiology, also able to do that. So depending on your institutions, you sometimes have both options. Patient is hospitalized for diabetic foot ulcer, receiving IV antibiotics for the osteomyelitis. The wound needs to be evaluated and dressed daily. Who is typically responsible for seeing and attending to the wound on a daily basis? Alright, the answer would be a wound care nurse. Yes, we have another nurse here who takes care of the wound, making a daily assessment on the wound, cleaning it, taking dressings, tracking healing progress. If the wound is looking bad, and then would probably need debridement, usually we'll have surgery on consult, and then debride the wound. Okay, 68-year-old patient with metastatic adenocarcinoma diagnosed 3 months ago, admitted again with recurrent pneumonia, likely due to airway obstruction from the mass. His conditions has been worsening. He has been gone multiple hospitalizations. You feel like we need the goals of care discussions here. Who is the most appropriate team to consult for this discussion? This probably should be very easy for you. Okay, the correct answer is palliative care team. The palliative care team help 2 things for the patients. They help patients who are terminally ill or very, very complex disease in symptom management and goals of care. So those are the main thing that the palliative care do. So in this case, we typically consult palliative, and they will talk to the patients and then try to discuss about what is the best for the patients. They will discuss about the goals of care. Now, patient with the same thing, metastatic adenocarcinoma, has a lot of pain. You want to start an opiate. You're not sure about the type, the dose, titration. Who is the best consultant to help manage this patient's pain effectively and safely? Okay. The correct answer here is, again, palliative care team. The palliative care team helps with the symptom management and discussion of the goals of care. Sometimes they use hospice, right, to transition if they feel like it's aligned with the goals of the patients and their families. But in addition to that, the palliative care team is really good and specialized in managing symptoms, whether the symptom is nausea or pain or low appetite or feeling ill in general. So they help to manage the symptoms in patients who are terminally ill. Alright, a 72-year-old patient admitted to the hospital with severe GI bleed. He received multiple units of packed RBCs. CT angiogram shows active bleeding from a branch vessel in the GI tract. The patient is not a surgical candidate, remains hemodynamically unstable. Who can be consulted to help stop the bleeding? So press pause, and then when you're ready, press play to go on. Here the correct answer is D, Interventional Radiology. They can perform angiographic embolization to identify and stop the active bleeding. Okay. In some cases, the GI surgeons will also be involved, and then they kind of like make decisions together on what's the best for the patient. 60-year-old man is admitted with fever, cough, and shortness of breath. The imaging shows a large loculated pleural effusion, and thoracentesis confirms empyema. Chest tube is placed, but the drainage is minimal, and there's a lot of localization. The team wants to consider giving TPA into the pleural space. Who should be consulted to do that? Now, most of the time, the one that able to do that would be the interventional radiology. Yes, in cases of empyema regulated effusion, you can consult the IR to administer like TPA and DNAs to break those loculations, right? And then facilitate a better drainage. Next, a patient with diabetic foot osteomyelitis is being managed with IV antibiotics. The surgery team is consulted for possible debridement. You want to clarify if the patient is scheduled to go to the OR today, but the surgeon is currently in the OR and not available to talk. Who is the most appropriate person to page to discuss the plan for this surgical consult? Okay, so the answer would be PA. Physician assistant is like the APRN, they are mid-levels. PA can be a PCP or they can also work in a hospital. And most of the time, PA works with a specialist that usually require a lot of procedures because they have to focus on doing the procedures, and therefore for a lot of things like notes or taking page on consultations, things like that, they can use a PA. Now, surgeon is just one of them, but I've seen a gastroenterologist surface use PA. I've seen oncologists use PA. That way the consultants can really focus on the medical decision making. It's 11 p.m. Your patient is rapidly deteriorating and needs to be transferred from the medical floor to the ICU. However, the nurse tells you that no ICU beds are currently available and you're unsure how to proceed with getting the patient moved. Who is the most appropriate person to contact to help resolve the issue and coordinate the transfer? Here, the correct answer would be the nursing supervisors, which I already explained before. The nursing supervisors usually in charge in the ward operations during the shift. They handle the bed, they may handle the staff issues, unit transfer, and some urgent logistical coordinations, especially the after hours. Okay. A patient with osteomyelitis and a history of CKD stage 5 admitted, labs showed worsening kidney function, fluid overload, rising potassium, nephrologist consulted, they recommend to start dialysis. Who would be the one that performed the dialysis? Okay, so yeah, the correct answer is the dialysis nurse. So the nephrologist is going to be the one that makes the decisions, and they're going to be the one that usually put the order in for the dialysis, but the one that execute that order is usually the specific person, a dialysis nurse. A 35-year-old man comes to the emergency department and tells the triage nurse, I feel like hurting someone. I've been having violent thoughts toward my coworker. The ED physician evaluates the patient, confirms he has active homicidal ideation. Who is the most appropriate team member to involve next for further evaluation and placement planning? So this question is also going to be pretty easy for you. Yes, the answer would be the crisis workers. And I already explained to you, usually they are licensed social workers, so they can evaluate the mental health, and they usually work in the ED for patients who have a suicidal and homicidal idea. An elderly patient is admitted after stroke. A swallow study shows he is not safe to take food or liquid by mouth, and a feeding tube is placed. The medical team needs to decide what type of nutrition formula to use through the tube. Who is the most appropriate team member to determine the feeding regimen for this patient? You can press pause, and then when you're ready, press play to go on. Yeah, the correct answer is the clinical nutritionist or the dietitian. The nutritionist will determine what type of tube feeds, Gevity, Glucerna, or something else, right? And they will determine how many kilocalories the patient should shoot for, and then what's the rate, etc. A patient with worsening COPD exacerbation admitted with increasingly shortness of breath and concern for CO2 retention. The physician orders an ABG to evaluate the patient's respiratory status. So who usually draw the ABG? You can press pause, and when you're ready, press play to go on. Okay, the correct answer is the respiratory therapist. Now, sometimes the intern or resident able to do the ABG as well, but usually the one that carries that machine to analyze the blood gas is the respiratory therapist. So, respiratory therapist usually is the one that does the ABG. Now, 70-year-old patient, history of COPD, admitted with worsening shortness of breath. On exam, he has increased work of breathing, and his ABG shows elevated CO2 and respiratory acidosis. The physician decides to start the patient on BiPAP. Who is the appropriate team member to assist with setting up and managing the BiPAP machine? All right, so the answer here, again, respiratory therapist. Respiratory therapist does the ABG, they manage BiPAP, CPAP, they're going to be the one that does that. In certain institution, they also provide inhaler treatment, and if it's in the ICU, they are going to be the one that kind of press the buttons on the ventilator machine, of course with the decisions from the physician. And then if it's time to extubate, the respiratory therapist is going to be the one that extubate the patient. 35-year-old man admitted to the hospital with active homicidal ideation. He's awaiting psych evaluation and remains a safety risk to others. The team decides that he requires continuous 1-1 observation to ensure safety. Who is typically assigned to provide this level of close monitoring at the bedside? The answer is the 1-1 sitter. But the 1-1 sitter can be anything. Usually it can be the nurse or nurse that nursing supervisor gonna be the one that finds out if there is somebody who can actually become a sitter. But yes, we have something called the 1-1 observation. So, and they will just gonna sit and then watch the patients, making sure the patient doesn't kill themselves. A patient with osteomyelitis is admitted and need to have detailed conversation about treatment options, risk of long-term antibiotic. The patient speaks only Spanish and you don't speak Spanish. What's the most appropriate action to ensure accurate and ethical communication? Now this should be very, very easy. You always answer, use a professional medical interpreter. Now sometimes they are in person. Sometimes you have this kind of like telephone thing that you can carry, not carry, but you push around and then get to the patients. They can do some video call type of thing, and then they can translate for you. Sometimes it's just a phone, but either way, it's a professional medical interpreter is the one that is recommended. If you use professional medical interpreter, and then you will have to document that you use that, and then you put some ID or something for the professional medical interpreter as the documentation. Sometimes patients prefer to have their family member to translate. You still need to document the fact that you have offered the professional medical interpreter, and if they refuse that, that is their autonomy, and then you just follow. But in general, we will like to use a professional medical interpreter. It's kind of USMLE questions, so it's not that difficult. So a 35-year-old man admitted with homicidal ideation begins to escalate. He becomes agitated, loud, physically threatening towards the staff. The situation is no longer safe and verbal de-escalation is not working. What is the most appropriate next step? Now, if you have been paying attention, you should also be able to answer this question, right? Answer is code gray. This is the usual one, but could be a different color in other institutions. But basically, you want to have the security comes and then help you if it becomes like really bad. Usually before that, they call or page the residents, whoever, to give the Haldol or Zyprexa or whatever to calm the patients down. Now, if it gets to become very, very dangerous, then you can call the security. So now we have discussed pretty much all of the people that I mentioned here. We talk about the job the hospitalist, right? The one that admit the patients, sometimes writing the notes if there is no residents, and then writing the orders, the one that in charge to discharge the patients, and the one that make decision on the consults. We have the consultants, like nephrologists do the nephrology thing, cardiologist does the cardiologist thing, so I don't need to explain that, but I did explain about the role of palliative, and then we have the interventional radiologist that can do multiple things for us. I describe the difference between a social worker, case manager, and a crisis worker. We talk a little bit about the physical therapy role, and then speech therapist and dietitian. We talk about respiratory therapist. We talk about multiple people here, some technicians, phlebotomist, EKG tech, echo tech. We didn't talk about the echocardiogram tech, but they exist to do for the echocardiogram, and then EKG for EKG tech for EKG. And we discussed about different type of nurses like the CNA or LNA in New Hampshire, RN nursing supervisor. We have wound nurse, we have dialysis nurse, we have a PICC line nurse, and we have mid-levels like the APRN and the PA. We also talk about security, like interpreter and the clinical pharmacist. So those pretty much sum up the main people and their roles, and you have answered some of these questions, right? I hope that you have the idea of their role and responsibilities and when to call for their help, because now you know what they actually do, so you can deliver care for the patient in the US healthcare system. Hope that's helpful, and I'll see you again in the next video on part 3, which is the inpatient facilities.